Good day. I first of all would like to thank the American Society of Clinical Oncology and the Russian Society of Clinical Oncology, as well as Dr. Kristina Sakrideva and the RAC Fund team for the invitation to participate in this clinical trial workshop. It is an honor for me to be here and speak with you. I'll tell you a little bit about myself. I have been doing clinical trials, actually oncology clinical trials, for the last 22 years. And my experience is on all phases of the clinical trials. I've done phase 1, phase 2, phase 3, as well as registry protocols. But now, then let's go into the data collection, which is really my topic. When we do talk about data collection, we talk about the data, and that is what is analyzed to determine the results of the clinical trial. Documentation is the first step in managing the data. Like we say always in medical fields, if it was not documented, it was not done. We need to document what was done and what was not done. This includes the procedures performed and discussions between healthcare team and the patient family, such as the informed consent process. Who did you talk to? Did you talk to the patient? Was it there? In the informed consent process, we always let the patients know the participation is voluntary. So all these things we need to document and in our clinical trial. The good clinical practice compliance Cardinal rule, according to the International Conference on Harmonization of 1996, tells us about the case report forms and that the source document and medical records must match data point to data point. And there is a reason for that, as we will see, because source documentation is the beginning of a clean, verifiable clinical trial. So the ICHF, it was actually the first to determine the definition of source data in source document. So what is source data? Source data is all the information in the original records and certified copies of the original records of clinical findings, observations, or other activities in a clinical trial necessary for the reconstruction and evaluation of the trial. The source data are contained in the source document, which are really the original records or the certified copies. So the source data is really the source document placed in the case report form. So the source data entered in the case report form, what we call CRFs, are obtained from the source documents. Some examples of source data are medical history information, medical examination results, lab results, demographic data such as date of birth, the gender, the weight, patient ID number, study number, drug dispensing information, informed consent document. Source data is also, for example, the IRB approval date. Sometimes the protocol gets amended just because we realize that we need more information, we need more data to collect, or perhaps if something was not as clear before. So the IRB approval date is important because it let us know when can we collect the data that we are collecting or that we should be collecting. It also includes visit date, concomitant medicines, intercurrent illnesses, and of course, adverse events and side effects, because we also collect this for the safety of the protocol and of our participants, the subjects. And then we go to the source documents. So the source documents are the original documents, the data and records of observation or activity. And the purpose is to document the existence of the subject and substantiate the integrity of the data collected, to include original documents related to the trial, to the medical treatment, and to the history of the subject. Some examples are hospital records, clinical and office medical charts, laboratory reports, patient diaries, quality of life questionnaires. And this includes, as you see, things that the patient himself or herself have documented too. So everyone can document in the protocol as a source document. It can come from the physicians, it can come from the clinic, but it can even come from the patient themselves. Evaluation checklist, pharmacy dispensing records, diagnostic reports, and surgical reports. Case report forms also is where the information, the data is recorded or collected. So the case report forms can be either paper form or electronic forms. Like I told you, I've been doing this for 22 years. I recall when I first started, most case report forms were paper forms. Sometimes we even had that the patients would have like 2-3 big binders of information contained in the paper forms. And then we also have the electronic case report forms that are the ones that are mainly used right now. Can a case report form be a source document? Only if it's stated in the protocol that the data will be documented directly in the case report form. For example, sometimes quality of life questionnaires that the patients go ahead and fill out themselves or complete themselves. We can just give a patient a pad or a tablet where they can just answer the quality of life questionnaires directly into that source. So then that would be seen as the source document. And it needs to be signed and dated, of course. We can also do documentation of case report form corrections. This happens because sometimes the data management team can send queries or questions to clarify data that has been entered in that case report form. So we do this to document all the changes and the additions or corrections made to the case report form after the initial data were recorded. It has to be signed, dated, and completed. If it's in paper forms, you can just cross out a line, put your initials, and date it. If it's electronic case report forms, of course, there is data trail, that every time that somebody just logs into the computer, they know who did it and then what time and what the change was. At the end of the study, the case report form for each patient is signed and dated by the investigator to confirm that the observations recorded and everything in the case report forms is verifiable and correct. We have data quality, of course. When we have data collection, when we have source documents, we need to ensure that the quality of the data is consistent. The data quality is really dependent on the accuracy of the source documentation. And this is because, as we said from the beginning, the source document goes to the source data and goes to the case report form. So that's why if we don't start with the source documentation, which is accurate, we will not end up with data quality at the end in the case report form. There are some challenges to do this, of course, because the protocols sometimes occur over a long period of time, sometimes years. So we have many members of the healthcare team documenting data in the source documents. And maintaining the continuity of the documentation practice can be really difficult. Sometimes we can see that we want to document just like we would do for standard of care practices, but the protocols may demand that we document in more detail. We may want to see specific times and when something got started, when it stopped, how many milliliters of this, what was left over. So we just need to make sure that we are continuously training any personnel or staff that comes into the conducting the clinical trial. And also another challenge is that the patients may be treated in multiple locations. And if they go to a clinic or a hospital or any other place, we need to know that all the documents are considered source documents. So we perhaps may have to just go ahead and then go and contact other hospitals, other clinics or offices to obtain the documents that we are for the source documentation that we need for the clinical trial. Now, the data quality, we call it ALCOA in English, but it is because we have it so we can remember the A for attributable, the L for legible, meaning we really need to be able to read or write, not just the documentation, but the signature. If we have a physician that can sign that they did something, but nobody documented who was signing that, and we cannot understand the signature, we will not be able to know who performed that study or who performed the documentation. It has to be contemporaneous, it has to be original, and of course, it has to be accurate. There is the data integrity as well, and we have the 3 C's. We call it has to be credible, it has to be consistent, and it has to be corroborated, meaning that we really need to show that it did actually exist. At the end, we have the case history, which is the source documents along with the case report forms. And you say, well, where is the data source? Well, the data is what is put in the case report forms. So in the case history, we have source documents that we utilize to gather our source data. And this data is what we enter in the case report forms. So a case history includes the case report forms and any supporting data, the sign and data concern forms, any medical records. So what this means is that in the case history, we have source documents, we have the medical records, we have research documents, and then we have the case report forms, the electronic database where everything was entered. So if somebody comes to look at your trial, if any federal agency wants to come and question the validity, the integrity of your trial, they will come and they'll ask for the case history, which is this, the source documents along with the case report forms and the data collected. When we talk about data collection, of course, we talk about data management. I know another colleague will be speaking about data management later on during this clinical trial workshop. I'll just touch very briefly to tell you that data management is done to ensure that the contents of the case report forms are properly entered into the clinical database. The data management team also issues queries to study site for data clarification and completeness. That's when I was telling you about that sometimes we make corrections in the case report forms, and it is because we have been issued queries for data clarification and completeness. And they also, the data management codes the data into an analyzable form. So what we see is that an important aspect of the clinical research life cycle starts with the collection of the data based on the source documentation that we have, all the source documents. Any data that we enter into a case report form, if there's no source document to back it, it's not valid. Then we have the processing of the data, the storage of the data, of course, and the sharing of the data for analysis, which is actually the core of data management. And here you say, well, why are we talking about the protocol again? And it's because I want to just make sure to emphasize that the protocol document is really what's going to tell us what data to collect, when to collect it, by whom. Then we have a delegation of authority log, which in principal investigator is really assigning this or designees to be able to conduct different aspects of the clinical trial for him. And the protocol also tells me the data points, the baseline. When does the baseline start? Can I, at baseline, and I need an MRI report, is this MRI report be 14 days old or 30 days old? So the data points are very specific. And as well for the on-study. When does the patient come on study? What triggers the on study? Is it the treatment, or is it when anything else happens that is in the protocol? The entering point, what are we collecting between the time that the patient starts the treatment until the end of treatment? And then this is the end of treatment. When do we stop collecting data? At the end of treatment? Is it that the subject finishes participation in the study when they finish treatment, or is it at the end of the study? Are we following the subject also for survival, progression-free survival, overall survival? So all these things are written in the protocol and allow us to really capture that data in the case report form. So it is very important to be very clear in the protocol about what data we need to collect, so then the case report forms can be built to be able to collect the data that we're going to need at the end of the study to analyze it to see if we met our objectives. So in summary, we have the source document plus the case report forms that give us the case history that the purpose of it is to be able to substantiate the existence of the subject and the integrity of the data collected. So the case histories lead us to the data analysis of the study to be able to see if we just went ahead and met our objectives. Thank you.